So let's get into it. We have insects, mycosis, and autoimmune disease that we're going to be covering today. So we have a couple of definitions, and these are all the various pathologies we're going to be going through. And the first definition I have for you is endothrix. So endothrix is going to be when you have a dermatophyte infection, which is a fungal infection. That's going to be infecting the inside of the hair shaft, okay? The outermost portion of the hair is going to be unaffected. Okay, this is called the cuticle, all right? Ectothrix is our next definition. So this is going to be where you have the dermatophyte infection affecting the outside of the hair. Specifically, it's going to be affecting the hair follicle, which is going to coat the outside of the hair in fungal elements and spores. All right, and with that, the cuticle of the hair is going to be destroyed. This is going to be relevant when we talk about tinea capitis later. All right. And then the last definition is gyrate. So you guys have seen this before. This is lesions that are going to be like whirling, parts with a circle, spiral, or twisted. Okay, and we'll talk about pathology where you can see that presentation later. But first, we're going to talk about spider bite. Okay, so we're going to be talking about two different spiders. There's the black widow spider, which is going to be this guy here. And then we have the brown recluse spider, okay? So these spiders are good to know because the board is probably going to ask you at least one question about these spiders, okay? And they're unique not only in their physical characteristics, but also in the type of venom that they inject and the effect that that venom has on the person who has been bitten. Okay, so they're really easy to differentiate between the two spiders, and if you can kind of just nail down those details, it's easy points on the exam. Okay. Now, something else to just mention here is that these spiders, despite how creepy crawly they are actually not out to get you. Okay, and oftentimes when they bite people, they are just biting them, injecting them with a little bit of venom, and then fleeing. Okay, so most people do pretty well with these bites. All right. But something else to kind of just mention here too is that it's hard to study and know how many people are being bitten by these spiders each year because they run away. And the only way you can identify what caused a certain bug bite is by having a picture of the bug, having captured the bug, and having an entomologist identify that bug. Okay, so you guys actually encounter that in clinical practice. I have it happen all the time where patients will come in and say, "I have a bug bite. What did it?" Okay, and my answer is, "I don't know. I wasn't there." Okay, I can infer maybe based off of some of the characteristics that I'm seeing in the bite reaction, but there's no way to definitively know. Okay, all right. So you guys might encounter that. Okay, so let's first talk about the black widow spider, which is Lactrodactys mactans. So this spider is going to be black in color, just like what you're seeing here. Okay, it's going to be shiny, it's relatively small, and one of its most notable features is that it has this red hourglass shape, okay, on its abdomen. That's going to help you identify. All right, the black widow spider lives in all 50 states, and it's typically an outdoor spider. Okay, so you're going to find it in like wood piles and gardening sheds and tool sheds, toolboxes. All right, areas typically where there's clutter. Okay, that's where it's going to feel safest. All right, but one of its other more notable places that it likes to be is underneath the seat of an outhouse seat cover. Okay, so if you should ever find yourself in the unfortunate situation where you have to use an outhouse, I hate to say, you might want to like flip up the seat just to make sure one of these little guys isn't underneath there. It's going to give you a little bit more than far before you sit down. Okay. Previously, before we had indoor plumbing, the common area to be bitten because people were using outhouses was more like the genital region, like inner thighs, buttock area. But nowadays, because we don't use outhouses so much, it's going to be more so the extremities. Okay, so it's going to be like a classic area where people are going to be bitten. All right. So what happens when one of these little guys bites you? Well, it's going to cause a very classic lesion. It's going to be a target-like lesion. You're going to get this circular blanched area. Okay, it's going to have a surrounding red halo, and you're going to see what they call a central punctum. So a central punctum is going to be characteristic of any kind of bug bite. It's just where the mouth parts enter the skin. You're going to get like a little red dot. All right, if there's two fangs, you might get two little red dots. Okay, but that's just what it's going to look like, right in the center of the lesion. Okay. Now, when I should say the spider bites you, you're going to get a specific type of venom that's going to be injected. This is the neurotoxic spider. Remember that. Black widow, neurotoxic. okay? And with that, you're going to get more systemic effects, all right? So initially, depending on how much venom is injected, all right, at the site of the bite, you may just have localized pain if it's like a mild envenomation, okay? If it's more moderate, that pain can then travel from the extremity upwards towards the trunk, okay? You might have just localized diaphoresis initially, or you can have more generalized diaphoresis. And then usually within about an hour and a half time, you're going to get those systemic effects really coming into play, okay, with a more moderate to severe envenomation. So this is going to be like abdominal cramping, muscle spasms, abdominal rigidity, you can have partial paralysis, okay? You're going to start to see the neurotoxin kind of more at play there. All right. Uncommon though. Most people don't have this, you know, this sort of reaction here. All right. But it could happen. Okay. So with that being said, most cases, it's going to be a self-limited type of lesion, okay, envenomation. It's just going to last a couple of days. And you can manage your patient with just over-the-counter analgesics like acetaminophen or ibuprofen, okay? If your patient has more of a like moderate to severe presentation, obviously you're going to have to up your analgesia a little bit more. You might have to consider like morphine. You may also give them benzodiazepine, like lorazepam. That's going to help with the muscle tension. Okay. If it's a severe envenomation, then you may have to consider antivenom. All right. This is not readily available in most pharmacies because most people don't really need it. All right, but also it comes with some pretty significant side effects. And you have to make sure that the benefit is going to outweigh the potential risk in giving this antivenom to your patient. So what I mean by that, it can cause anaphylaxis, serum sickness, just as some more of its like serious side effects. So it's recommended you speak actually with a medical toxicologist prior to administering it to your patient. Okay, so it's not something to take lightly there. You don't just give the antivenom to everybody. All right. Now this is the, I'm going to show off this like the classic lesion. All right, so you're going to have that blanched area. If you look really closely, you probably see better on your own device. There is like a little small red dot. That's the central punctum right in the middle, and then that surrounding erythematous halo. Okay. All right. Brown recluse spider. So this is going to be Lysosceles reclusa. All right. So this spider, it's brown. Could be brown in color. Okay. It's going to have a very characteristic fiddle pattern on its what they call cephalothorax, which is going to be like the front part of the spider. Okay. So this is the violin. All right. If you guys look here, you can see like the neck of it. Okay. This is the body. You kind of trace it around. Okay. That's the classic fiddle shape. Okay. Or violin shape. That's going to help you identify this spider. Okay. Now, the brown recluse spider is typically found in like the Midwest, southwestern parts of the U.S. And it is one that typically likes to be indoors. This is not so much an outdoor spider. Occasionally it is, but it likes to be inside. But it's a recluse, okay? So it's not going to be hanging out with you on the couch watching TV, all right? This guy is going to be hidden away. It's going to be in like a dark basement, in cupboards, okay? Somewhere where it's just isolated, that the recluse would want to be, all right? But one of the areas that it does like to hide, all right, on like a main level floor would be inside of a closet in that pile of clothes that you keep at the bottom, okay, that you just kind of chalk there. All right, that's where they like to live, okay? They feel comfortable in there. Most people, when they get bitten, the reason they get bitten is because they pick up those clothes off the floor and they don't shake it out. They just put the clothes back on. They don't know the spider's inside, and then they end up getting bitten, okay? So should you live in one of these areas or be visiting one of those areas where these guys are found, you might want to just shake out that clothes before you put them on, okay? All right. If it is outside, it's going to be in like grass, like barns, okay, more fields like that, okay, wood piles. Okay, so what happens when this spider bites you, all right? Well, it's going to inject a cytotoxic venom, okay? Remember that. Brown recluse, cytotoxic venom. It's going to cause a reaction at the site of the bite, okay? No systemic effects really, just where the bite is. Okay, so it's going to start off as an erythematous, either papule or plaque, okay, that over time is going to change, okay, usually within about 8 hours. You're going to start to see this lesion expand, okay, it may get a dusky area within it where you're starting to see some ischemia, all right? The area is going to become very edematous. You might see the formation of some bulla or some vesicles, okay? And it pretty much, well, it has the erythematous red halo too. It's going to stabilize at this point, all right, for most patients, okay? Because again, the spider's not trying to kill you, all right? It's not trying to eat you. It's just biting you and fleeing, all right? So within a week's time, it's going to stabilize and it's going to heal and it's going to just run its course. 10 to 20% of the time, it's going to get worse. That area where it became dusky and ischemic is going to become necrotic. Okay, you can have an overlying eschar, and you could potentially have gangrene that's going to form. All right, not common, but can happen. All right. Okay, so treatment for this is going to be ice compression and elevation, okay, of the area. For most people, again, it's going to heal. You're going to do mild analgesia, and they're going to be fine. All right. If it's more of a severe inflammation, then you have to consider, upping that again, maybe morphine. All right. This is a very classic presentation of the way that the lesion looks. You have that erythematous halo. You have your bulla, your vesicle, that overlying eschar that's going to be necrotic underneath. Okay. And if you look at this hand, the top of the dorsum, you can see that there's not really much in terms of like bony landmarks, like the knuckles, is very edematous. Okay. Now you might look at that clinically and say, well, should I debride this, right? Should I get rid of all that necrotic tissue that's there? Well, it depends. If the area is no longer expanding and it is stable, then you can go ahead and debride out all that necrotic tissue. If it's still expanding and changing, you leave it alone, okay? Otherwise, you can cause too much inflammation, just disrupt the area and cause it to worsen. So you have to kind of watch and see before you go in there and start debriding anything, okay? Make sure it's stable first. And then for some patients, for like slow healing wounds, you may have to consider a hyperbaric oxygen treatment, okay? All right. Pediculosis. So pediculosis is going to be the condition of being infested by lice, okay? So we're going to be talking about 3 different types of lice that are going to infest humans, okay, in different places. So first we're going to talk about pediculosis corporis, okay, which actually doesn't infest the body, it just affects the body. Okay, where it's going to infest is it seems the clothing. All right, so that's why I put this here. All right. Then we have pediculosis pubis, which is going to infect the pubic area as well as the eyelashes. And then we have pediculosis capitis, which is going to be your common head lice, okay, affecting the scalp. So these lice are part of an order of insects called Anopleura, that literally means blood-sucking louts, and that's what they are going to do. They're going to affect these areas. They're going to feed, and they're going to, parasitize the host and suck their blood. And basically, the hallmark is going to make them very, very itchy. Okay, so that's going to be very characteristic across the board. Now, these lice, they do not fly, they do not jump. They're going to be spread skin-to-skin contact. Okay, so that could be casual contact, that could be sexual contact, and they can also be spread via fomites. Okay, all right. So let's talk about pediculosis corporis first. All right, so I already told you guys that they like to live in the seams of clothing. Okay, they'll just travel to and from the body to feed, and then they'll go back to clothing for their daily business. All right, whatever they do. They lay eggs and eat. Okay. Now, you see pediculosis corporis typically in like overcrowded living situations. You can also see it in like prisons, refugee camps. You're going to find it in situations where people don't have access to washers or dryers. Okay. If they did, this wouldn't be an issue. It just simply washing the clothing would eradicate this problem. Okay. So it's going to be in, when they don't have access to it. All right. Okay. Pediculosis pubis. So this is going to be spread through sexual contact. You're going to find it in the pubic region. All right. Again, as well as the eyelashes. This particular type of lice has larger, like claw-like appendages. It just allows them to latch onto thicker, coarser hair. They don't tend to move around. Once they like pick a spot, that's their spot. All right. So they don't wander too much. They're a little hard to see in this picture. There's a couple of them, but I circled one here for you guys so you can identify it and see it. Okay. All right. Then we have our pediculosis capitis. All right. So again, that's going to be your common head lice. You're going to see it pretty commonly in the general population, but it's going to be seen mostly with young girls. They have longer hair, they tend to share hair accessories, and they easily just spread the lice around to one another, okay? So that's a picture of one up close. You can see it actually has blood in its thorax. It's feeding off the scalp here, okay? Here we have the lice eggs, which are called the nests, right? So you're going to see that usually the occipital, scalp, and postauricular areas, okay? They'll take on like a cream kind of color when there's a viable louse inside. So louse is singular, lice is plural, okay? When there's a louse inside the egg, it looks brown. Once they hatch, they're going to take on more of like a white-gray appearance, okay? There's nothing inside, all right, the egg. Okay. All right, so we pretty much covered everything on this slide. I'm going to just keep it moving. So how are we going to be able to describe what we're seeing and identify when there is a infestation present? Well, you're going to see the adult insects, you're going to see the nymphs, and you're going to see nits, okay, the physical manifestations of these insects. But you're also going to see a papular urticarial rash at the site of the bite, okay, and excoriations because your patient's going to be scratching against. It's going to make them very itchy, okay. All right. So when it comes to pediculosis capitis, how are we going to treat it? Well, across the board, whether we're talking about capitis, pubis, or if we're talking about porphyris, okay, washing clothing on high heat, okay, and drying on high heat is going to kill these insects. And you're also going to treat all contacts at the same time. So you guys are going to see that flow through each of these slides. All right, that information, okay. Specifically, when we're treating pediculosis capitis, though, we're going to use a medication called permethrin 1% cream. Is probably the most common one. It goes by Nick. It's over the counter. All right. It's neurotoxic, as many of these medications are, to the lice, and it just helps them. All right. But the way that you're going to tell your patient to utilize this medication is they are going to go home. They are going to get into the shower. They're going to wash with their regular shampoo. Okay. They're going to rinse. Not going to use any conditioner, all right? They're gonna get out of the shower, they're gonna apply the medication, leave it on for 10 minutes, and then just rinse it out, okay? They are then going to do something called nit combing, where basically they're gonna take the fine-tooth comb and just brush through their hair after the treatment, just to manually extract any lice or lice eggs that are there, okay? So it's like a two-fold treatment, all right? With permethrin, it usually takes a second treatment, like a week later, okay, to totally eliminate the infestation, all right? Another option would be a pyrethrin. So this would be brand name Red, okay, if you guys have ever heard of it. It's an extract from the chrysanthemum flower. Okay, it also is going to be neurotoxic to the lice and kill them. But something to keep in mind if your patient has a ragweed allergy or if they're allergic to chrysanthemums, it's probably not the medication for them. All right, it's going to be applied in the same exact manner that I just described for Nix. All right. Then we have malathion gel. So this medication is a one-time treatment. Okay, it's left on the scalp for 8 to 10 hours, so usually overnight. Great that it's one time, but some of the caveats to it is that it smells really bad and it's highly flammable. Okay, so you have to tell your patients to be very careful, not go through any heat or any, near any heat sources, anything that could potentially ignite the medication. All right, might get rid of their life a little. So probably not a good idea. Okay, so not the medication that you're going to want to reach for. All right. Then there's topical ivermectin. So this medication, also a one-time treatment. It's only left on for 10 minutes, similar to Nix. All right. It's a nice medication to use. It works well. It's just expensive, sometimes a little hard to get covered by insurance. Okay. And then I have lindane down here. So lindane is a medication that really most people don't use anymore. Okay, it's actually banned in some states because it can cause neurotoxicity to your patient. Okay, especially if they use it after a shower. All right, and that can lead to seizures. It can also lead to death. So we don't really use it. Okay, the board sometimes likes to throw lindane on there and ask you about the side effects of it. So now you know. All right, but we don't really use it for treatment. Okay. Okay. Pediculosis, porphyris, right? So again, treatment is going to be improving hygiene, washing clothes. That's going to eradicate this infestation. All right. But with that being said, you're just as a precaution going to give your patient a topical medication to apply to their skin in case at the time when their clothing was being washed, there was a couple of lice feeding to them. All right. You don't want to leave them behind because once they put their clothes back on, reinfestation is going to occur. Okay. So you're going to give them 5% permethrin cream. It's going to be applied from the neck down. Okay. It's left on for about 8 to 10 hours, so usually overnight. Okay. It's a one-time treatment. It's going to kill off any lice on their body. All right. Okay. And just as a reminder, so you can see all the little lights here, that's kind of what they look like when they're infesting the clothing. This is that papular urticarial rash that you can see on the body, all right, that's caused by them feeding. Okay, pediculosis pubis. Okay, so treatment for this, permethrin 1% cream, okay, applied to cool, dry skin, left on for 10 minutes, okay, and then washed off. This infestation can be a little bit trickier to get rid of, so you have to usually retreat in like 9 to 10 days. Why 9 to 10 days? Well, because if there's any eggs that are left on the body, they take about 6 to 8 days to hatch. So you're going to let them hatch, and then you're going to retreat again and get rid of them. Okay? I'm trying to capture them. All right? 9 to 10 days later. Now, you're not going to use that permethrin cream on the eyelashes. Okay? That wouldn't be ideal. So instead, what you're going to use is an ophthalmic petrolatum. All right? You're going to apply it over the lice that are there. It's going to suffocate them, and then your patient is going to just manually extract either with fingertips or with a nit comb the lice that are present. Okay? All right. Scabies. So scabies is going to be a mite. So this is different than the lice that we talked about because it doesn't sit on the surface of the skin. This one is going to burrow into the skin. All right? So this mite goes by the name of Sarcoptes scabii. Okay, it's that little guy there, it's a little flattened oval mite. All right. When it causes an infestation in an individual, they're going to pick it up usually through direct skin-to-skin contact, possible through fomites, but not as common. It's really going to be skin to skin. Okay. Now, with that being said, the mite that stays on the skin, or in the skin, I should say, is going to be the females. The males are going to stay on really just long enough to mate, and then they fall off and they die. All right, but the females are going to be the ones that remain. Okay. Now, the reaction that your patient is going to have, okay, the lesions that are going to show up are typically going to show up 4 to 6 weeks after the mite is already present, because this is a delayed type 4 hypersensitivity reaction, okay, to the mite, to its species, and to the eggs that are present. It just takes time. All right, if your patient has never been exposed to scabies before. If they get reinfected, okay, and they have a subsequent exposure, their reaction is going to happen in about 24 hours. Their body is used to it, all right, or aware of it, I should say, okay? All right, so what type of presentation are we going to get with this? So your patient is going to have usually erythematous papules, sometimes fascicles that are going to be present on, really it's can be anywhere on the trunk, okay? But you can see it classically like finger webs, the wrist, the axilla, right, the areola, the genital regions, okay, just to name some of the spots. But most often when you see it, it's going to be that, okay? But finger webs, toe webs for sure are usually affected, okay? You're also going to see burrows, okay, that very classic lesion. So that's best represented by that picture up there. You guys have seen it before, okay? This is where the mite is burrowing through the skin. You can see that track. Okay, does anybody remember the test that you could do? Although this is the clinical diagnosis to help confirm the presence of scabies. Scraping. I heard scraping, yeah. And what kind of scraping? Who's saying it? Oh, there you are. Sorry. Yes. What are you going to apply to collect them so that they don't get you? KOH. Not KOH. Mineral oil. Mineral oil. You're so close. So yes, it's going to be a mineral oil scraping. Okay. That oil is going to suffocate the mite and hopefully kill them so that they don't infect you. And then you, exactly as she described, put it onto the slide and visualize it. Okay. And then you're going to see that little guy there. Okay. All right. In terms of your patient's history, they are going to tell you that they are extremely, extremely, extremely itchy. And it's going to be so much worse at night. Okay, and the reason for that is because these mites are nocturnal or active at night. okay? And they're going to be moving around a lot, all right, during that time, okay? All right. Treatment. So it's going to be the topical permethrin 5% again, okay, like we talked about with Diculus corporus. It also goes by the name of elamite, okay, that might be a common name you guys have heard maybe before, all right, as this is not uncommon in the general population, you can see it, all right, but it's going to be applied again from the neck down, left on overnight, washed off in the morning, okay, so usually somewhere between 8, maybe 14 hours on the long end, okay, and then it's going to be retreated again a week later. So if your patient does a treatment on a Friday, they're going to do it once, wash it off. The next Friday, they're going to do it again. All right, just to make sure that the infestation is gone. This is safe in lactation. It's safe in pregnancy. It's really like the gold standard treatment for treating scabies. Okay. Oral ivermectin can also be utilized. It's an oral medication, so it's going to have more side effects you have to be aware of. You don't really use this in pregnancy. And you have to caution use with children who are less than 15 kilograms, okay? With that being said, too, this is a weight-based drug, okay? So you have to do some calculations before you administer it, okay? You're gonna treat all contacts, all right? So that this way it's not spread around. And in terms of like bedding and clothing and those sorts of things, you're gonna seal it away for about 72 hours before washing, all right? These mites don't live very long off the body. So within 72 hours, if you've sealed it away, they should all be dead, and then you can safely throw them into the, the wash and dryer on how to eat. Okay. All right. Your patient may have persistent itch even after treatment. This is not uncommon. All right. They still have this delayed hypersensitivity reaction going, and it generally left to the eggs and the, well, not viable eggs anymore, but the feces, okay, that's left behind in their skin. They're still reacting to it. So this can sometimes pose a little bit of a challenge with these patients because they're going to feel like they're still infected and they're going to be uncomfortable and it's going to give them anxiety. All right. So what you can do to help alleviate that kind of emotional aspect to this and also take away the itch is give them a topical steroid, okay, that they can use for spot treatment wherever they're feeling a little itchy. All right. I think it's a nice thing to do. It kind of keeps them treating themselves and it just helps them feel better and also helps with the delayed hypersensitivity reaction. So it's kind of a win-win. All right. Triamcinolone would be like a common steroid to use. All right. Okay. Now, the other thing I just wanted to mention to before I forget, with scabies, so you don't typically get this from fomites. Not like someone's going to be sitting down and then you sit down and then you pick it up, right? That would be uncommon. Unless they have something called Norwegian crusted scabies, which is like a hyperinfestation of scabies where they have millions and millions and millions of them. And they're shedding so many off into the environment that if you were to like be in close proximity and sit somewhere where someone else got, then you might then pick it up. Okay. If you guys are interested, it's kind of interesting to read about. It's very hard to treat. But anyway, okay, fleas. So fleas are a very common insect infestation. I think most people are familiar with, especially if you have pets. Okay, like cats or dogs. This is not something that's going to infest a human, all right, but it will infest those little furry friends, and from them can bite a person, okay? So what happens is the animal gets infested and the fleas will typically drop off, okay, or fall off, and they might fall off into carpeting, and as someone's walking around, they will jump up and bite at their ankles. All right, so you're going to get these erythematous non-follicular papules, just like what you're seeing here. They can be pretty itchy, okay? These fleas, believe it or not, can jump very, very high. They can even jump up to 2 feet. So they got powerful legs, I guess. It's like 150 times their own length, so they can get around. Okay, they're going to be a clinical diagnosis. You're going to see the lesions when you know it, or when you see it, and the treatment is going to be a topical steroid for your patient's symptoms, okay? So like mid-potency is fine, like a triamcinolone should do the trick. You're also going to treat the source, which is the pets, okay? So that could be like giving your pet a flea bath, okay? Giving them a flea collar, or even they have like liquid medications that can be, put onto their backs like Frontline, okay? It's a common brand. All right, to get rid of the infestation on the pet, they'll take care of the problem. Occasionally, these fleas can also spread disease, okay, like typhus or the plague. So if your patient has these lesions and they're showing up with systemic symptoms, that's something you may have to think about, okay? Sometimes the lesions may be a little bit worse in their presentation, that they could be like necrotic or pustular, okay? So just something to keep on your radar. Okay. Chiggers. So chiggers are a type of mite, okay, that can be found outside. Most people are affected by them in the fall and the summertime when they're doing outdoor activities. They'll pick up this mite when they are, walking around. They like to kind of just sit on the edges of blades of grass and then get onto the clothing. All right. They look just like this in the adult form. Okay, they're like 1 to 3 millimeters in size. They're kind of reddish in color. All right, but it's actually the adults that aren't the problem. It's the larvae. Okay, and the larvae are going to be microscopic. You can't see them. All right, but when they get onto someone's skin, they're going to know they're there because they are going to make them extremely, extremely itchy. Okay. These mites are notorious for wandering around before they find a place that they think is suitable to be, okay, to get them to their next stage of life. All right. So what ends up happening is they eventually get restricted by clothing. So they'll get restricted by like a pant line or like, sleeve cuff or something like that. They can't get any further. And that's where they're going to have to stop to feed. So you're going to get clusters of bites in those areas. All right, that's going to help you make this diagnosis clinically when you see it. All right, okay. And with that, you're going to get erythematous papules or sometimes papular fascicular rash. Okay. Now, I did say it's a clinical diagnosis. Okay, but you could do something called tape stripping. So tape stripping is essentially you take a piece of tape and you put it over where the lesions are. You try to collect one of those little larvae, and then you put it underneath the microscope and try and identify it. Okay, that's going to confirm your diagnosis. All right, but if the history matches, you see those clusters of lesions, your patient's complaining of being extremely itchy just a few hours after lesions showed up, you can assume it's probably chiggers. Okay, make sense? Okay. So treatment for this is self-limiting. These little bugs, they're not looking to stay on the body. They're just feeding again, get a blood meal so they can drop off and go on to their next phase of life where they start to feed off vegetation and other things. So the whole reaction, everything only lasts maybe like 1 to 3 days. Okay, and then everything kind of falls off. But you could tell your patient that if they've been outdoors and they're starting to get these bites, to go into the bath or shower and scrub really vigorously to try and dislodge any of these mites that may be present. All right. Other things that your patient could do is wear appropriate clothing, right? Just like what we talked about with Lyme disease, long sleeves, long pants, everything tucked in, all right, to limit access points, and use insect repellents like DEET. All right, that can be helpful too. Okay. So now we're going to talk about dermatophytes, which are skin plants. So skin plants, because if you break down the word dermatophyte in Greek, dermato meaning skin, phytes being plants, we have skin plants, and we're talking about fungi. Okay, so these are going to be a specific group of fungi that's going to infect non-viable keratinized areas. So like the stratum corneum, okay, of the skin, the hair and the nails. All right, so we're going to talk about a couple of different presentations of what you can see with dermatophyte infections. So there's different classifications for these dermatophytes. I picked the one that's based off of spread, okay, because I think that's just the easiest to remember. So there's anthropophilic spread, which is going to be person to person, zoophilic spread, which is going to be animal to human, and then there's going to be geophilic, so that's going to be from like the environment, say like soil, all right, for example. What you're going to see is going to be based off of the site, your patient's immune response, and also the species of dermatophyte that's present. Okay, and we'll talk about that. There's 3 different genera. So there is Trichophyton, with Trichophyton rubrum species being the most common. So you guys are going to see that as a trend throughout this lecture. The etiology is oftentimes going to be Trichophyton rubrum. Okay, Microsporum. Okay, with Microsporum canis being very common. This is usually zoophilic spread, and then there's Epidermophyton. Okay, so how someone gets a dermatophyte infection. This is just for your guys' knowledge, all right? So you don't have to worry about this one. But basically what's going to happen is there's going to be some sort of compromise in the skin barrier. So it could be like maybe they have atopic dermatitis, right? They have more permeable skin barrier. It's going to allow for the dermatophyte to get in, or maybe there's a maceration to the area, occlusion, all right, that's going to cause the skin to break down, be compromised, trauma, whatever the cause, the dermatophyte is going to get in, it's going to take up residence. And in this picture, it's going to be represented by the green circles and lines, okay? It's going to stay within the epidermis, okay? More specifically, like the stratum corneum. There's a reason for that. They produce keratinases that break down the keratin, which allow them to grow, okay? There's also micronutrients like iron that are going to be freely available, all right? That you can only find in the epidermis. And the dermis is going to be bound, okay, by transfer. So it's not going to be readily available, all right? Now, these dermatophyte infections, they don't typically cause a major immune reaction, okay? They don't produce a lot of toxins or byproducts, so they can take up chronic residence without causing too much of an issue, okay, in our patients, all right? Now, they're going to affect, again, not only the skin, but also the hair as well as the nails, and we'll talk about some of the presentations with that, okay? Predisposing factors, okay, so atopic dermatitis, right, other cell-mediated immunodeficiencies, topical steroids, because they are going to basically dampen down the immune response, which is going to allow the fungus to grow. Same is going to be true with systemic immunosuppression, so like oral prednisone, okay, or if your patient is on immunosuppressive medication, okay, fungus can take hold, or if they have like, a disease, say maybe like HIV or other immunosuppressive disorder, okay? Fungus typically like warm, moist environments. That's just where they thrive, okay? So anytime there's any occlusion on the skin or an intertriginous area, there's going to be sites, or even between the toes, okay? There's going to be sites where fungus is going to like to thrive, okay? You can also see that with like obesity, with redundant skin folds because of the occlusion, right? And then hygiene, right? If your patient's not cleaning their skin well, obviously fungus is going to be able to live, all right? So in pediatric patients, we typically see these infections on the scalp. Young adults and older individuals, it's going to be intertriginous areas. And then elderly, it's usually nail infections, okay? So some testing we can do for these dermatophyte infections. So KOH, all right, which I know you guys are familiar with. Okay. Other options, so culture, all right? So basically this would be taking a vial that has a specific medium in it called Severod's glucose medium, all right? This is just a medium that the fungus grows well on, okay? And you take a sample, depending on what's going on with your patient, could be skin flakes, all right, that you drop into the vial. It could be a nail clipping, it could be cell bone pool debris, it could be a plucked hair. Whatever the source is that where the infection is occurring, you can put into this vial, all right, and watch to see what grows. It takes about 4 to 6 weeks. Once you start to see growth, you're going to take your vial and you're going to send it off to the lab, and they're going to look at it and tell you exactly what's taking from it, all right, so you're culturing it. Now I have up here that you need to do this before any kind of PO antifungal treatment. That's just because that's what the textbook says, okay? But nobody really waits for the culture to come back. You're going to have other faster methods for treating your patient's fungus than waiting for that. This would really play a role, I would say, clinically, if your patient is refractory to treatment that you're giving them, then you might want to find out exactly what's needed there, okay, for more targeted treatment, all right? But for its purposes and for textbook purposes, you do a culture before you do the treatment, all right? Okay. Other options, so Wood's lamp. This is basically just going to be a black light that you're going to shine onto your patient's skin in a darkened room, and the lesions are going to fluoresce. Okay, now depending on what species is there, they can fluoresce different colors. So Tinea versicolor is going to fluoresce yellow. Okay, Microsporum canis, okay, or any of the Microsporum species are going to fluoresce green. All right, so that'll help you identify it. I'll show you guys pictures too, so it'll all make more sense. Okay, so what do you guys think is going on in this picture here? KOH, exactly. All right, you guys have seen this before. That's how you do it, right? You just take your little microscope slide, like your scales, put it underneath the microscope, a little KOH, and visualize what you need to. All right, this here is going to be essentially someone who's taking a curette and they're trying to collect subungual debris. okay? And likely they're going to take that curette and that sublingual debris and put it onto that glucose medium for a culture, okay? Run it along the medium. Little clinical pearls, should you decide you want to do this, you're going to want to clip back the nail if your patient has long nails before taking your sample, okay? Because if they have long nails and they're walking around in the environment barefoot, they're going to pick up a lot of contaminants, okay? And if you just try and take a sample right off the front of the nail, you're going to get all sorts of stuff, all right? So clip back the nail, then take your sample, okay, where there wouldn't be any contaminants. Does that make sense? Okay. Now, the question is, well, if I have a really thickened fungal nail, how do I clip that, right? It's hard. Can't do that really well with regular nail clipper, so they have what they call a nail nipper, okay, which is just a very large nail clipper, okay? And you can use that to kind of crunch down through those thicker nails, okay? In this picture here, you know, if you want to take a sample of the nail plate, I would say do the same thing that I just said when you're taking a sample of sublingual debris. Clip off the most distal portion, and then get rid of that. Take another sample, okay, a little further back so you don't get contaminants, okay? And then you can take that nail plate, send it off to the lab for test day. All right, makes sense? Okay, little clinical pearl too for that. Use a piece of gauze after you've lined up your nail clipper, okay, put a piece of gauze over it, and then clip down, because if you don't, what ends up happening is that nail plate is going to shoot across the room, okay, or land in your hair, all right, and you walk around with it all day, and that's just really gross. You want to collect it, right? It's not the worst thing in the world if you lose the sample, okay, other than walking around with it, but, you know, you could just take another piece. Just save yourself some time. Just cover it, let the gauze catch it, and then you put it into your bottle, all right? Okay. Okay, so KOH, these should look semi-familiar to you guys. So this is going to be tinea versicolor, where you have your spaghetti and meatballs appearance, okay? This is going to be Candida, where you have your pseudo-hyphae and budding yeast. And then this is just what the culture looks like, okay, the culture vial. Some fungi will grow characteristically, kind of eyeball them, but you should always send it out to the lab, even if you think you know what the species is, okay? Like Candida looks like tapioca, right? Okay, this is your Woods lamp. So this is where you're going to be shining that black light, okay, onto your patient's skin, okay, in a darkened room. So with tinea versicolor, it's going to look kind of yellowish. With the mycosporium species, again, it's going to look more green, okay? And then here, this is actually not fungal, okay? This is something called erythrasma. So sometimes what can happen is you'll have a patient that you've been treating with an antifungal and they're not getting better, okay? It could be erythrasma, which is actually a bacteria, okay, that mimics a lot like a fungal infection, okay? So when you shine it, you'll see that coral color, you'll know that it's erythrasma, and it's usually treated with erythromycin or clindamycin topically, okay? Easy to do, quick test. So for antifungal treatment, topicals are usually going to be your mainstay. This is going to be your imidazole, okay, your azoles. So ketoconazole, clotrimazole, miconazole, and so on. But there's other antifungals that are topical that don't end in azole, like cyclopirox, which is Loprox, or nystatin. There's a ton. All right, so you have a lot of options to pick from, which is nice. Now, if your patient has too many lesions, okay, the topicals is not practical, or if their infection is affecting within a hair follicle, then you may have to consider oral treatment, all right? So that's going to be your systemic, like terbinafine, which is Lamisil, okay? Itraconazole, fluconazole, which is diflucan, or griseofulvin. You know, with some of these medications, they can affect the liver, okay, like Lamisil or griseofulvin, so you may have to do more routine testing and check LFTs prior to administering the medication or checking them as they are harnessed, okay? All right, so let's talk about tinea capitis. Okay, so this is going to be a fungal infection that is affecting the scalp, okay? There are a couple of different presentations for tinea capitis. So the first one we're going to be talking about is this picture here and this picture here, okay? So this is going to be your gray patch tinea capitis. This is going to be ectothrix infection. So it's affecting the outside of the hair shaft, which is going to make the hair and the area look gray, okay? It's just fungal spores and elements, okay, that you can see. all right? Now, this is going to be massively scaly, not so inflammatory, okay? So not like a ton of erythema. You can see areas where there's going to be alopecia, okay, or hair loss. That's going to return, okay? The hair will come back once the fungal infection is gone. And something else you might note is that the hairs break about 2 to 3 millimeters above the scalp, okay? And that's because there's still integrity to like the center of the hair, so it has durability. It can grow a little bit before it snaps, okay? Which is going to be different than your black dot tinea capitis, okay, which is an endothrips infection, right? So you have infection inside the hair shaft. There's really no integrity to that hair. It's all compromised. So once the hair gets to the surface, okay, any kind of friction or trauma or anything, it's just going to cause the hair to just snap right off, right at the top, okay? And when you look down, it's going to look like a bunch of little black dots. This is just you looking down at the hair shaft, right at the opening of the hair follicle, okay? The hair follicles also look a little bit edematous, okay, in their appearance. This can have some scaling and, you know, patches of alopecia too. Again, once this is treated, it's going to come back, the hair, all right? Then we have a carrion. So a carrion is going to be a really inflammatory presentation of tinea capitis. All right, this is going to have boggy lesions. You press on it, there's going to be pus that comes out. It's going to be very painful. Your patients usually don't feel great. They can have post-auricular lymphadenopathy along with this. Okay, and because it's so massively inflammatory, if it goes untreated, it can destroy the hair follicles and you can get permanent hair loss in those areas, okay, that are affected. Right? Okay. The etiology for this, so most commonly is going to be trichophyton tomzorans, okay, at least that's here in the US. In other parts of the world, geographically, these species is just going to be different. So Microsporum canis is going to be more common in like Europe and Africa and Asia, okay? But again, geographically where you're at, there's going to be others too, okay? All right. So you're going to see this most commonly in pediatric patients. It is a clinical diagnosis, but you could certainly do your KOH or culture if you need to. For, I would say, gray patch and black dot tinea capitis, it's mostly just itchy, not so much painful. The carrion's going to be more painful. Okay. So because this is affecting the hair follicle, you are going to need oral treatment. Okay. Anytime you get a question on the boards that says, you know, this is tinea capitis, you have to, you know, assume it's affecting the hair follicle. You have to do oral treatment. It's going to be the answer every time. Okay. I will tell you though, clinically, if you have someone who has tinea capitis and it's really mild, you could give them a topical. Okay. The idea here and why the boards want you to take the oral treatment, that a topical theoretically can get all the way down through the hair follicle. So infection can persist. Okay. With oral treatment, it's just clear it out. All right. It's going to penetrate systemically. But like if it is very mild, you might be able to get away with topical. Okay. Or it's oral. All right. Pretty much, yes. Yeah. You're going to do your oral antifungal. Okay. So that's going to be like griseofulvin. Okay, is a common one. Terbinafine or Lamictal would be another one. Okay. You may have to check liver function for your patient with these. It can affect the liver. Griseofulvin is also going to be a weight-based drug. And you're going to tell your patients to avoid, you know, sharing towels or brushes or pillows or anything that might, you know, spread the infection. Okay. All right. Tinea corporis. So this is going to be where you have the dermatophyte infection that is affecting the trunk and the extremities and the nape of the neck. That's going to define tinea corporis for you. All right, there's a very classic lesion that we're going to see, and it's going to look just like what you're seeing up here. All right, you're going to get these erythematous, either patches or plaques, that are going to have an elevated or raised border. Okay, that's going to be erythematous. It's going to have peripheral scaling, which you can really see well in that picture here. So scaling just along the edges, and then central clearing. Okay, it's an annular ring-shaped lesion. All right, that's the classic presentation. You're going to see this presentation carry through a lot of the slides in the different areas that we're talking about the fungal infection. Okay, all right. Now, sometimes these lesions, as the condition worsens, they can kind of coalesce together and you can get more of like a gyrate pattern, okay, on the skin, just like what you're seeing here. all of these little circular patches or plaques kind of just coming together and creating this whorl. Okay. The other thing I just wanted to point out to you here in this more like plaque presentation, if you look at the superior border, like on the right top, you can see that there's vesicles there. So sometimes when you have zoophilic spread, so from like animal to human, it can be more inflammatory and you can get vesicles that may be present. Okay. All right. This is from a guinea pig. Somebody was put in a guinea pig and they ended up getting the infection. Okay, this also goes by the name of ringworm, all right, which I think is like the common kind of the name for it, most people are familiar with. And the etiology is going to be trichophyton rubrum, okay, most commonly. Okay, transmission, so again, direct contact, we see this oftentimes with wrestlers because of the hobby and the nature of, the sport, they end up becoming, very close contact to one another, and they spread it that way. Gym use, you can pick it up from the environment from using gym equipment. Also, if you think of like occlusive clothing again, so like that can trap moisture and heat and create the warm environment for fungus to thrive. Okay. It can be spread, infection again, animals from pets, from other people in the home. You can also auto-inoculate different areas. So if you have, say, tinea capitis, right, and you're scratching and picking at that area, and then you scratch your arm, now you have tinea corporis, all right? You can kind of spread it around. That's not uncommon with these fungal infections. Other medical reasons, so again, anything that causes immunosuppression can lead to a fungal infection. Hyperhidrosis, so like excessive sweating, can also lead to, especially in the axilla. This is an occlusive area. It's just a good place for it to grow. Okay. And then xerosis, so dry skin, right? Any kind of compromised skin barrier can allow the dermatophyte to get in. All right. Okay. Clinical diagnosis can be itchy. Unlikely it's going to be painful unless you have more of that inflammatory presentation from an animal where maybe those vesicles break down and you get eruptions. All right. Treatment for this is going to be antifungals first line topically. So we know that there's a ton you can choose from, right? And the duration of use and the frequency of use is going to be dependent on which one you pick, which is like too many options to put on the slide for you guys. So I just gave you an example. All right, of ketoconazole cream, which is pretty widely used. Okay, it's going to be once a day, and they're going to use it for 2 weeks to the lesion. Now, something to just mention here, you want to tell your patients to treat, okay, about an inch outside of the lesion. All right, and that's because these lesions will expand. They're going to grow out peripherally. All right, so that elevated erythematous border that you see, that's where the fungus is most active. Okay, it's advancing from. But doesn't mean that some of the fungus hasn't already advanced past that. Okay, you want to treat whatever might have already started to spread. Okay, so they have to treat that whole area outside. If it's, unresponsive to topicals, okay, then you have to consider them maybe giving them oral, antifungals. Okay. Tinea purus, exact same presentation of the lesion that we just talked about, that annular lesion, right? Erythematous raised borders, peripheral scaling, central clearing. It's just going to be in the groin area, okay, or inner thighs. Sometimes it's unilateral, sometimes it's bilateral. You can get both, okay? This is also called jock itch. We're going to see it more in like the spring and summer where people are just sweating more, okay? Something to note here is that this individual also has tinea corporis, right? Because now it's not just affecting the groin, but it's also affecting lower down on the thigh and above the knee, all right? So they have both. It's possible that they could have just spread it from the groin to their leg, all right? But something I would want to do is look at their feet, okay? Because athletes would, especially when, someone comes out of the shower and they're toweling, can spread from their feet up their leg to their groin, okay? So you want to check that, okay? You may also want to check their fingernails too to see if they have any fungal fingernails that might be spreading things around, okay? All right. Let's see, most common cause, again, trichophyton rubrum, all right? So in terms of other predisposing factors, actually, it's pretty much all the same. Honestly, you guys are going to see this be pretty redundant throughout the slides. I'm just going to try and pick out the information that might stand out for each location. All right, so we're just going to kind of move through it. All right, so diagnosis is going to be, as previously mentioned before, you could do clinical, but you could do KOH or culture, okay? It's going to be Again, a little itchy treatment, topical antifungals is going to be the way to go. But because of the nature of the area, you're going to want to recommend that your patient try to increase evaporation and reduce perspiration. So, keeping the areas cool, clean, dry, wearing loose clothing, promote kind of airflow through the area is going to help prevent these fungi from growing and, inhibit them if they're there. All right, antifungal powders can be utilized. So like a Zeazor powder, okay, you can get over the counter, can be used for maintenance. All right, and then weight loss, right, for those redundant skin folds, okay? And then telling them to carefully towel and do not scratch. Okay, tinea pedis. So this is going to be athlete's foot. So this is got a couple of different presentations, so we'll work off the slides for this, but this is going to be the most common dermatophyte infection. All right. So with that, you're going to have the moccasin type. All right, so that's this picture here, okay? So, or these two, I should say. You're going to have more of like a hyperkeratotic, like more scaly kind of presentation with variable erythema that's going to affect the sole of the foot, the lateral aspect of the foot, and then over the top, all right? Almost as if someone was wearing a moccasin type of shoe, all right? That's why it's called the moccasin pattern. Here we have the most common type, which is going to be interdigital. All right, so this is going to be between the toe webs. All right, you're going to see scaling, peeling. You can see erosion. Sometimes you can see fissures, and you can also see maceration. Okay, so that's really going to be very common between like the third and fourth interspaces or interwebs. Okay, there's just a lot of occlusion there. So it traps moisture, which allows the skin to become macerated. Do you guys know what maceration looks like or what it is? No, it's where the skin just becomes very, I'll show you a picture, but it becomes very white, very moist. It breaks down really easily. Okay, so just picture like very, very damp, heavily hydrated skin. Okay. Okay. All right, so sometimes with tinea pedis, the rash can start between the toes, or sometimes it could be spread from tinea unguium, okay, which is infection of the nail. All right, so if I look at this picture here, I would say that little pinky nail looks a little bit suspect to me. All right, it's a little bit thickened, a little yellow. It's possible that this whole infection started there, or it could start between the toes and then spread down to the nail. Okay, but it's just something to look out for. All right, this is the bullous type. Okay, inflammatory bullous. So with this, you're going to get bulla, okay, that are going to be on the medial aspect of the foot, okay, or on the instep. This can be a little painful. And then we have the rare ulcerative type. Okay, so with this, you're going to get exactly what it looks like, ulcerations that are going to happen. It can happen between the toes. It can happen on the plantar surface underneath the toes. It's like an interdigital sort of presentation. It's just worse. Okay. If you guys remember when we talked about cellulitis, right? One of the potential like predisposing factors to getting cellulitis was tinea pedis. Well, that would be a perfect reason, okay, for bacteria to get in and cause cellulitis too, as a complication. Okay. All right. So, let's just see if I've got anything. Most common etiology, T-root worm, okay? Now, for predisposing factors, all the same stuff. Just things to keep in mind. You want to tell your patients to avoid occlusive footwear, wear breathable shoes. That's going to help, keep airflow again, and hopefully they won't get tinea pedis. Also, try not to walk barefoot, okay? Especially in locker rooms or around pools, because that's like good places to pick up this infection. All right. We see this very commonly between the ages of 20 and 50. About 70% of the U.S. has this. Okay. It's a clinical diagnosis. It's usually asymptomatic. Okay. Sometimes it could be a little bit itchy, and there can certainly be pain when you have that more severe presentation of tinea pedis. Okay, like the ulcerative type, or if you have any of the bulla with the inflammatory bulla type that are down. Okay, or vascular. Okay. So treatment for this is going to be, again, topical antifungals first line. I put an example of ketoconazole again. This is just going to be used a little bit more often, so twice a day and for a longer period of time. We're going 4 weeks for this treatment as opposed to 2 weeks all with tinea porphyris.
What are we doing for the fissures? Like, is that putting gauze on it? Or...
Oh, like the ulcerative type? Yeah. Yeah, so that's gonna go probably to the hair. That's not gonna work so much with your more common, just like interdigital regular teeth.
Are they able to like walk around with that, or should they kind of?
Probably not. Yeah, probably not. And you're probably gonna be treating them also for secondary infection too, because their skin is just denuded at that point.
We do like systemic antibiotics as well?
Potentially, yeah, absolutely. It's something you have to consider, but it's a pretty bad infection when it happens that way. It's not very common, but you can see it from time to time. Okay, so other adjunctive treatment for your just regular run-of-the-mill tinea pedis is going to be keeping the shoes clean and dry, so the feet. You can also recommend that your patients use Lysol, okay, that they can spray onto a paper towel and clean the insides of their shoes. You just want to make sure that it dries for 24 hours before they put their feet back in, just so they don't get like a contact dermatitis, right? But that'll kill off any fungus. Keeping the nails short is going to be important too, so that there's no spread to the nails. Okay. Zigazor powder, again, is an over-the-counter powder you can just throw right into the shoe as well. Topical keratolytics like salicylic acid or urea cream can be utilized. This really works well for the moccasin type where you have those really thick scales. Okay. This is going to just wear down the scales and allow for the antifungal to penetrate better. Okay. Clean shower and bathroom floors using bleach is going to kill off any of the fungus that may be present so they don't keep reinfecting themselves. That's going to be important, okay? And then if refractory, so PO antifungals, okay, are going to be the way to go. All right. Okay, tinea manuum. So this is going to be the dermatophyte infection affecting the hands. All right, this is oftentimes referred to as one hand, 2 feet syndrome. Okay, where someone's going to have tinea pedis on both of their feet, and then they're going to spread it to their dominant hand. Okay, and it's going to look just like that. All right, where it's affecting over like the dorsum of the hand, you're going to see that classic annular plaque. Okay, sometimes you can see little pustules in there because it's affecting down to the hair follicles, because sometimes people have hair on the top of their hands. All right, on the palm, you're going to see more like thicker white kind of keratotic scales. Sometimes fissuring, okay? Just like what you're seeing here. Okay? It usually just affects one hand. Okay. Other things to look for if it's affecting the nails. Okay. T. rubrum, again, is going to be the most common etiology, but there are certainly others. When it's spread through geophilic spread, it's oftentimes because people are using gardening tools, that have the fungus on them and they end up picking it up as they're, gardening. Or if they're not washing their gardening gloves, okay, they can also get it through that route, or just not using gloves at all and they're just in soil. All right, so sometimes you see that every now and then. Other predisposing factors, so like hand eczema, again, a compromised skin barrier. Okay. Everything's going to be pretty much the same. Topical antifungals is going to be your go-to. If you see it affecting the hair follicles on the dorsum of the hand, you see pustules, you may have to then consider the oral antifungals. Okay, tinea barbae. So this is where it's affecting the beard region, right? So we talked about this in lecture 4, right? We talked about psychosis barbae, which also sometimes can be fungal, right? So this is it now coming back again. It's the fungal presentation. It looks exactly the same, all right? But you're just going to treat with an antifungal, right? So that's this picture here, right? If you guys remember, it's like those deeper seated, more erythematous nodules have central pustules, okay? But you can also get the presentation where you just have that annular plaque, okay, within the beard region, right? This is going to be most common in people, usually men, who work on ranches, who have cattle or horses that they're working with. They're going to pick up the fungus from those animals. So it's Trichophyton verrucosum is going to be from cattle, and then Trichophyton metagraphite declinum is going to be from horses. Okay, that's going to be the species that's really causing the issues here. Okay. So treatment, because it's affecting the hair follicle, is going to be, again, your PO antifungals. Topicals are going to be ineffective. You're going to want to do, though, remember, like either KOH, you're going to plug out a hair and look at it under the microscope to see if there's fungal elements present versus bacterial cause, right? We talked about with psychosis barbae, right? You're also going to want to plug out some hairs to send out for culture as well, okay? Tinea incognita. Okay, so tinea incognita is kind of perfectly named for what it is. It's going to be a fungal infection that is incognita or incognita. Okay, it's not obvious. All right, it's the history here is usually that your patient has gone and seen a provider who looked at their lesions and thought it was like an inflammatory, like eczema, okay, and gave them a steroid to use, okay? And they're gonna tell you, I use this steroid all the time, but my rash isn't going away. It doesn't hurt, it doesn't bother me when I use the cream, okay? But the second I stop, then it gets intensely itchy, okay, and becomes uncomfortable. Sometimes there's burning to it, all right? But it's just not going away. That's going to be like the classic history. And I'll explain why that happens. So when you put a topical steroid right on the fungus, it dampens down the immune system, right? So you're not going to have symptoms of itching or burning or anything like that. But it's going to allow for the fungus to grow. So the rash is going to keep getting bigger, okay? And once they stop using the topical steroid, the rash is just going to flare up. The immune system is going to start working again. It's going to cause itching, burning, and discomfort. Make sense? Okay. So when we see this presentation, it's hard to identify because it loses that annular plaque or patch presentation with elevated borders and all the characteristics of fungus. Instead, you're going to get variable patches of erythema, might be a little bit more intensely red. It's going to have less scaling. You might see pustules that may be present. It just looks nothing like the classic fungal infection that we talked about, okay? Making it hard to identify, all right? Now, if you were unsure and you're in the office, you could do a KOH, okay? And it's going to be very, very, very positive because the fungus has been allowed to grow. So there's tons of fungal elements, okay? Likely, if you're not able to do that, you're going to be doing a biopsy, okay? And when you get results back, it's going to tell you that there's fungal, fungus present, and then you're going to make your diagnosis from that, okay? So treatment is going to depend on severity. Again, you might go topicals if it's not so bad. If it's affecting over hair follicle or if it's extensive, then you have to consider your oral antifungal. Okay. And then tinea unguium or onychomycosis. So onychomycosis is like an umbrella term that is fungal infections of the nails, but includes not only just dermatophytes, but includes yeast and non-dermatophyte molds. Okay. So tinea unguium is a dermatophyte infection, it just falls under the umbrella of onychomycosis, okay? And there's a couple of different presentations for it. So you guys don't necessarily need to know this, but this presentation here, this is distal lateral subungual onychomycosis. So you're gonna get a little bit of lifting of the nail. The nail on the distal and lateral ends is gonna look more like yellow or white, okay? Here we have superficial white onychomycosis. Okay, so this is where it's affecting the nail plate, but only on the surface, okay? This responds really well to topicals, okay? Here we have where it's affecting the fingernails, okay, but this is gonna be due to candida. So you see this more commonly with like people who bartend or people who are like house cleaners, people who constantly have their hands wet. They end up getting a paronychia due to candida, and then it spreads to the nail plate. And the nail is going to look yellow. Sometimes you'll get like a little greenish tinge or some little black dots that you can see throughout the nail plate. Okay. Here, this is like your classic tinea unguium, where you have like a very yellow dystrophic nail. There's going to be subungual debris, all right, underneath the nail plate. When the nail gets this bad, it's very hard, even with treatment, for it to like come back and be normal. It's not common. Sometimes it just grows back dystrophic, and that's just it is what it is, even if there's not fungus there. Okay. The other thing I just want to mention here is that you want to make sure you do a nail clipping, all right, before you give your patient treatment for this, which is going to be oral antifungal. Topicals is not going to help this, all right? But the reason you want to do your clipping, you want to confirm the presence of a fungus, okay? That's going to be really important because on your differential diagnosis, it's psoriasis, okay? So you don't want to just assume when you look at it, oh, this is fungus, when indeed they have psoriasis, and then you put them on an oral antifungal that has effects on their liver, all right? So you got to check it out, all right? Confirm your diagnosis before you start treatment for that, okay? All right. So when we're talking about tinea unguium, most common etiology for the toes is going to be Trichophyta rubrum. All right, for the fingernails, we're talking about Candida albicans. Okay, all the same stuff. When it comes to diagnosis, again, so it's going to be that nail clipping. You're going to send it out for PAS. That's what it's called. So periodic acid shift testing. It's just a test that the pathologist is going to do on the nail plate to confirm that there is fungal elements. All right. So you do your little clipping, you send in the biopsy file, and about a week later, you'll get your results back. Okay. In terms of your patient's symptoms, I just want to mention this here. Usually asymptomatic, occasionally can be painful though, because these nails become really thickened, and just compression on top of the nail from like their shoes can cause pain. All right. There's ways to like basically smooth down and wear down the nail. That can be helpful for your patients. Sending them to podiatry is always a good idea. All right. They have like spinning birds and stuff they can use to just smooth out the nail, so that's not a problem. Okay. And then anxiety can also occur in your patient because they're just not happy with the way that their nails look. Okay. So you want to make sure that you're sensitive to that. All right. So treatment, systemic, okay, is going to be usually the way to go, especially when the nails are very heavily affected. So Lamisil, okay, for example, you're going to do LFTs prior to starting the medication, okay, and then once a month, and they're going to be on it for a total of 3 months. All right. It does work well. The other option, if you have like that superficial white onychomycosis, okay, where it's just affecting kind of superficially off the nail, you might consider them topicals, all right? So a common one would be Cyclopirox 8% nail lacquer, which is also called that. And it's like a nail polish. Your patient just paints it on daily, all right? They do that for 7 days. At the end of the week on the 7th day, they're going to take an alcohol pad and they're just going to basically wipe off the medication that's built up on itself and then restart the process. Okay. That takes up to a year to be effective. So you have to tell your patients to be diligent, okay, to continue on and to just, run the course, even though it's going to take a really, really long time. If they're motivated, they'll do it and they'll clear the infection. Okay. Other options, so the YAG laser, I would say that this is more common in like podiatry offices. It has variable efficacy. It's a laser you can use on the nails. And then candidiasis, you're looking at PO, itraconazole, okay, to treat that. The other, topical antifungals I have listed here are very similar, okay, and how you use them. All right, they're just other options. Great. 5 minutes.
Those days are long ago.
I love her pink nail.
Yeah.
I look forward to it. Yeah, I'm like, where, behind the curtain.
Yeah, no, really? No, you heard what my brother said today? How about
No, my goodness. Guys, you got it. Wow. Wow.
And that's the street. Yeah. And one birthday girl.
Do you want
What?
They're good? Yeah. It is perfect. I told her, like, I'm like, okay, got it. Thank you. Bad that I like actually. And I'll like, okay. Like, oh, better like her. They must have it. There, and then when we get to this budget, I don't know what we're talking about. You have it. I had this. I looked up. Oh, I noticed Sean. I haven't watched it. No, I haven't watched it. Okay.
Yeah.
Wait, John, what were you saying? Oh, that's I think I'm doing myself because I wrote on the thing that I live nitro like the different I think so like but then in the diagnosis I don't understand like get nitro or I haven't been yeah, that's where you like yeah. I remember being like, don't like it doesn't I never still make that might not like that shit works yeah, and then it can't hurt. I mean, unless they can I don't really know about that. All I know about micros is like it's all going micros. Yeah, but it is like in there already like if they're but if it's like still normal time, yeah. Hours. How the one I forgot that I forgot. Oh yeah, it's fun. I feel like I have so much. I went down about I really think this is my I might but now I really don't I yeah, I like don't post it. No, like something like I'm there. I'm definitely like yeah, well, no, everyone thinks it's blockers. Bit of blocker. Yeah, just guy. Yeah, all I love. You're going. Yeah. It's not her. I like it's just something like say every hours. I'm like, I wait 20 minutes. Then I just you know, I meant to. Oh, it's sorry. I'm just like not I think like or sort of change like sort of it's like that's better than just like like yeah so like mine and he's like it's like every something is right. And not really like that, so like
Like, I'm really 5 hours.
I think we can do it.
So, Intracrigo is going to be, basically, a inflammatory process happening, okay, with a secondary infection, okay, that's occurring. So a good way to remember this is in Latin, inter trigo. So inter means between and trigo means rubbing. So you're going to see areas where there's going to be skin overlying each other, okay? And in between that, you're going to get inflammation and you're going to get maceration. You're going to get occlusion in these intertriginous areas, all right? The friction and the rubbing is going to break down the skin and you're going to get secondary infection, okay? Candida, pretty common. It's already on the skin and just gets in and causes rashes in our patients. So what you're going to see classically are these beefy red plaques, okay, that are going to have also satellite lesions, okay, little lesions outside of the main area, all right? And sometimes they're pustules, sometimes they're just papules, but it looks just like that. It looks very, very red, okay? It's gonna look angry, all right? Now, with this, some risk factors, okay, are going to be all of the things that you expect, all right? It's going to be an occlusive area, you know, whether it's in the axilla or in the groin, okay? You're going to have that increase in moisture, hyperhidrosis, immunocompromised state, but also incontinence is going to play a role too. So, you know, you'll see this in like elderly and pediatric patients, right? You know, who might be wearing like diapers, and they end up getting an rash, the Candida trigo, because of the incontinence, you know, the waste product, they're basically going to wear down the skin. It's going to allow for the Candida to get in. Make sense? All right. So diagnosis for this is clinical. Okay, you could do your KOH and you're going to see your vitamin B pseudohyphae that you would expect to see with Candida albicans. It's going to be pruritic. Okay, sometimes it's going to be painful, especially when there's erosions that may be present. All right. And treatment for this is going to be your topical antifungals. All right. So nystatin, clotrimazole, ketoconazole, some of the common ones. All right. But you might adjunct your treatment with a low potency topical steroid because remember the main process that's occurring is inflammatory. All right. So using like a hydrocortisone 2.5% cream is usually common ones for looking at those intertriginous areas, and we're worried about the side effects that can come with topical steroids, right? So you go low potency. The way that you're going to have your patients do this is they're going to apply their hydrocortisone in the morning, okay, and then do their antifungal at night, or vice versa, just one in the morning, one at night, all right? And they'll keep the hydrocortisone as part of their regimen for about a week, okay? That's just going to get them over the flare of this, okay? Calm down that inflammatory reaction, and then that'll fall off, and they'll just follow with their antifungal to treat the Candida, okay? Usually for an additional week, but like a 2-week course, okay? All right. Prevention. So remember to have proper hygiene. Keep, you know, everything clean. Okay, you want to keep everything cool and dry. So you could even recommend for your patient after they get out of a shower to help dry up these areas, to take their hair dryer on like a low setting, okay, and just dry it, okay, so this way the skin doesn't become too moist, all right, and you don't run into this problem, okay, all right, and then weight loss too. Okay, sporotrichosis. So sporotrichosis is going to be an infection caused by a fungus called Sporothrix schneckii, all right? So this is going to be a basically a fungus that is going to be transmitted through plant matter, okay? It's oftentimes called rose gardener's disease because people who like to, you know, take care of roses or tend to roses will end up getting poked by one of the thorns, okay? And the thorn is what's going to be harboring this particular fungus, okay? But you can also see it on other like decaying plant matter. So landscapers too can also pick this up as they're tending to yards, you know, but certainly florists for sure, okay? Some of the common people being affected by it. Now, what ends up happening? They get a trauma, right? The Sporothrix schneckii gets into their skin, and within about 20 days, they're going to start to develop a lesion, okay? Usually like a pink or purple nodule, all right? It's going to look just like this, okay? Eventually, over time, it's going to get larger, all right? It's typically painless, but it's going to become almost more pustular. It's going to break down, erode, and then serous fluid, or like yellow fluid is going to start pouring out of it, okay? Over time, if this goes untreated, you can get lymphatic spread. Okay, and just a short distance away, follow the lymphatics, you're going to get another lesion, okay? And this is the same patient, it's going all the way up their arm, okay? That's just common with this condition that you can get the lymphatic spread, and it's one of the ways that's going to be helpful for you for diagnosing it, all right? Now, most patients will do well with sporotrichosis. They're going to be treated for about 6 months with itraconazole, all right? But with that being said, if they are someone who's immunocompromised, it can go from the lymphatics and spread oftentimes to the lungs, and then it could be fatal for that reason, okay? But most people, that's not going to be the case. All right. Tinea versicolor or Psoriasis versicolor, which is called pretty much everywhere else in the world except for here in the US, we call it tinea versicolor. So you might see in the literature as psoriasis, okay? It's a very, very common condition and one you guys should be familiar with, and I think you kind of are already. But this is going to be a rash caused by a yeast called Malassezia furfur, right? That naturally occurs on the skin. And oftentimes, you know, the history with it is that your patient, especially a young person, is going to go outside, they're going to try to tan, and they're going to have these spots on them that are failing to tan, and that's what's going to drive them to come into the office. All right, so really, I should also mention too, depending on your patient's underlying skin complexion, lesions are going to look a little bit different in terms of color. Okay, so if you have someone who's trying to tan or they have a darker skin complexion, lesions are going to be hypopigmented. Okay, just like this. If they have a lighter skin complexion, okay, the lesions are going to be hyperpigmented or sometimes hypopigmented. All right, but usually hyperpigmented. A good way to remember this pathology, versicolor. So when I see versicolor, I think of versatile colors. Okay, it comes in many colors depending on my patient's underlying skin. All right. So the lesions themselves, outside of, you know, whether they're hypo or hyperpigmented, are going to look the same. You're going to get these, you know, macular areas, okay, that may coalesce. You can get larger patches with just fine scaling, okay, associated with them. So what I mean by fine scaling is when you see it clinically, okay, what you're going to do with a glove tan is you're going to just lightly run your finger over the lesion, all right? And it's going to bring out all of this little tiny bitty flaking, okay? That's the fine scaling that you're going to appreciate. Otherwise, if you just look at the skin, it doesn't look very scaly, okay? All right. It's asymptomatic. Common areas, so it'd be like the trunks, the upper arms, okay? I'm sorry, upper trunk and arms, as well as like the back of the neck is very common. So in KOH, you're going to look for that spaghetti and meatballs pattern with wood slamp. It's going to fluoresce yellow. Ignore the green part here, guys. You really should know that it's yellow, even though it's yellow green. Just yellow. Okay. I want to confuse you guys. Treatment for this, so topicals is going to be first line. So that's going to be your antifungals, right? So ketoconazole cream is the common one to use, or shampoo, or even sodium sulfide lotion, okay, which is also glue. So you could use these on their own, or you could even use them as like a combo kind of treatment, where you have your patient use the sodium sulfide lotion prior to getting into the shower. They just kind of put it on their spots, okay? They leave it on for a few minutes, then they get into the shower, they wash with it, wash it off, okay? Get out of the shower, and then they're gonna apply their antifungal. They usually have to get rid of this pretty quickly, okay? Oftentimes too, you're going to recommend like a ketoconazole shampoo, just aside from that, just for maintenance, okay? When they're in the bath, they can just kind of lather with it, all right? Because this is going to come back, it just does, all right? The Malassezia furfur lives on the skin, so when the conditions are right, it's gonna flare, and that's usually gonna be during the summertime, all right? But you could try to keep it under control with maintenance. Okay. If it's very widespread, then you may have to consider your systemic therapy. So that would be like fluconazole or diclofenac would be the common one for that. Okay. All right. Autoimmune disease. So I'm really not going to get heavily into like the details of the autoimmune disease. This is more than what we need to know for dermatology. We're just going to talk about the skin manifestations. Okay. You guys will learn about the more, you know, nitty-gritty details in other courses. Okay. All right. So let's start with systemic lupus erythematosus, or SLE. So there's like 3 different forms of SLE. You can have acute, okay? You can have subacute, or you can have chronic SLE. All right, and it's going to have different presentations depending on where your patient is in that spectrum. All right, for our purposes, we're going to be talking about the skin manifestations you can see in the acute form and then also in the chronic form. Okay. All right, so in acute SLE, you're going to get the butterfly malar rash. Okay, so you're going to get this macular erythematous area over the bridge of the nose and onto the malar cheeks. Okay. It's going to classically spare the nasolabial folds. So you can see that they're not affected right in here. Okay, that's going to help you identify this. Sometimes you can have crusting and erosions within these lesions on the cheeks. Okay, so one of the most common precipitating factors for this butterfly malar rash is sunlight. It really for SLE in general, but for this, what can worsen it, bring it on is sunlight. So the more sun exposure your patient has, the worse this rash is going to get, the more flaking it's going to get, erosion can potentially occur, and it can be pretty uncomfortable for your patient. Okay. Then they can have a more generalized rash that's going to be affecting the arms, the back of the neck, okay, trunk. This is going to take on more of like a papular urticarial type of presentation. And that's what you're seeing here, okay, where it's affecting the arms. All right. And you can actually see it a little bit on like the V of the neck here too, okay, a little on the V. It's also going to affect over the dorsum of the hands. And what's most notable about it is it's not over the joints, okay? That's going to help you differentiate this from the next pathology. Notice how it spares over the knuckles, okay? But you have the rash just around it, okay? All right. Now for chronic SLE, okay, you're going to get what they call like discoid lupus. All right, so you're going to get these erythematous plaques. They're going to have really thick scales, okay? It's going to have an atrophic center, and when it's occurring over the scalp, you're going to get like a scarring alopecia, okay? All right. So in case, I didn't mention this before, but in case you don't know, so SLE is going to be an autoimmune disease that's going to affect pretty much all of the organs and the skin, okay, in the body, connective tissue. And oftentimes, about 85% of the time, there's going to be skin lesions that are going to be present in your patient who has SLE. Sometimes it's the very first manifestation of the disease, okay, even to begin with. So it's good to know, all right, and be aware of these presentations. Okay, so we talked about sunlight being a precipitating factor, so is family history, and then certain medications can lead to SLE, okay? So that's going to be hydralazine, anticonvulsants, and then procainamide. This is going to be most common in women. Typically, it's going to be African-American women between the ages of 30 and 40 years old. And when it comes to diagnosis, you're going to want to biopsy these lesions, okay, to confirm. So usually it's going to be a punch biopsy, and you're going to send it for direct immunofluorescence, okay, and lupus banded testing, what it's called, okay. And when the pathologist looks at the slides, what they're going to see at the dermo-epidermal junction, which is like basically that bottom of the epidermis between the dermis, that area, okay, like the big membrane. They're going to see IgG, IgM, and C3 just kind of light up in a band. Okay, that's going to confirm the diagnosis. Okay. You could do serology. Okay, so you could screen with an ANA. All right, that's going to be positive about 95% of the time. But then you can also do more confirmatory tests like anti-double-stranded DNA or anti-Smith. Okay, so this is additional blood work that's going to confirm that your patient has lupus. So you can start that in the dermatology office if you suspect it. All right. But your patient is honestly going to be managed most often by dermatology. All right, that's where they're going to go, really for any of these autoimmune diseases. Okay, so in terms of your patient's symptoms, so burning, itching, okay. If your patient is in that more like acute phase of SLE, they're going to have more systemic symptoms that are going to kind of go along with that, okay. All right, so treatment is going to be topical oral steroids. It really depends on how severe your patient is. If they have more widespread disease, then obviously you may have to consider oral steroids. If it's just like you're treating maybe just the malar rash and it's not that bad, you can consider a topical, okay, like mid potency would probably be best. If they're very, very severe though, you have to consider immunosuppressive, and rheumatology is going to help with that, okay? And you're going to tell your patients to rest and avoid the sun. Okay, dermatomyositis. So this is going to be a condition that is going to affect not only the skin, but also the skeletal muscles. All right, and there's going to be some classic lesions that you can see with this. So one of which is going to be a heliotrope, which is going to be like this violation, this coloration around the periorbital area. They're also going to have periorbital edema. So you can see like their eyes look a little bit puffy underneath. All right. And they're going to have what they call Groton's papules, all right, which are these violations, flat top papules that you can see over the joints. So different than what we saw with lupus, right? Lupus is spared over the joints. This is going to include them, all right? And you can also see these lesions around the elbow. Sometimes they can erode too, and they can be pretty uncomfortable, all right? Okay. This is a pretty rare condition. We don't really know much about the etiology of why it happens. But if you do have a patient who's over 55 years old, it may be related to malignancy, and you have to consider breast, GI, or lung cancers. Okay. So there's about 6 cases per every million. Okay, and when it comes to diagnosis, there isn't like a specific exact test to the diagnosis for you, but you can do a biopsy to see that, you know, you get basically a correlation between the findings and what you're seeing in the rash, okay, like the Groton's papules. But you're also going to want to biopsy the actual muscle, okay, so that's not going to be happening in the derm office. You know, you're going to send them out and refer them for that. They may have elevated CPK or ANA. Okay, there's further testing that can be done to help confirm. All right. Your patient's symptoms, so the rash itself is going to be itchy. Okay, the Groton's papules, not so much the heliotrope. All right. But your patient is also going to complain of issues with their axial muscles. So they're going to have issues going from a seated position to standing up or lifting their hands over their head as part of their, you know, their clinical history. Okay, make the diagnosis. Treatment for this, so there's an 8-year survival rate of 70 to 80%. PO prednisone, immunosuppressives may be needed. Okay, again, room is really going to be the ones to handle this, so methotrexate might be prescribed for them. All right. Okay, scleroderma. So this is going to be a condition that's going to affect the internal organs and also the skin, okay, as well as the vasculature. All right. So with scleroderma, this is also a relatively rare condition. There's going to be a couple of different findings. So you can have hands basically where your fingers kind of come down, they call them Madonna fingers, they like taper down, okay, to a point. That's because part of this process causes bony resorption of the distal phalanx. All right. So you get these kind of like tapered fingers. You might also note that the skin looks kind of shiny, right? Well, that's because it's becoming sclerotic. It becomes very hard. Your patient is going to lose mobility in their hands. It's going to be a very painful condition. All right. You might also note that this patient doesn't have all of their fingers. That's because they were amputated just purely out of pain. Okay. They were just removed. So that's something you may see. You can also see Raynaud's phenomenon, okay, with this. On the face, you can see a mask-like facey. They're going to lose their natural skin line, but the skin becomes more sclerotic and tight. They're going to get a beak-like nose and thin lips, okay? And you may see visible telangiectasias, okay, that can be present on the face. On the fingertips, okay, something else you might know too is little erosions, okay? This is before they really lose all of their mobility. Your patient is trying to pick up things and, you know, manipulate the world, and they've lost elasticity of their skin because it becomes sclerotic and hard. It's just going to break. Okay, you can get erosion of the fingertips. Okay. So the etiology behind this is not also really well understood. We think that it has to do with the endothelial cells in blood vessels becoming damaged, which leads to edema, and that edema leads to sclerosis of the skin, okay? And then also the finer capillaries that you have, especially like the telangiectasias you can see on the face, start to die off and other vessels dilate, all right? And that's what makes that presentation, okay? The telangiectasias pop up. Okay. So 20 per million clinical, okay, diagnosis. You can do a biopsy, you're going to screen them with an ANA, and then there's other further blood work testing, like SCL70 that you can run to check to see if your patient has scleroderma, okay. The survival rate for this is going to be for 10 years, 50% spontaneous remission occurs, but not often. Okay, again, you're going to refer, they're going to get systemic steroids or immunosuppressives. Okay, and emollients are just trying to keep the skin a little bit better hydrated. All right, but just again, this is going to affect internal organs too. Okay, so like the heart, lungs can also be affected. That's why there's a mortality rate associated with this. Okay. All right, and then last one. So this is going to be necrobiosis lipoitica. So this is a rare granulomatous disease where your patient is going to sometimes have it associated with diabetes. You're always going to want to check them for it. 1/3 of the time they're going to have diabetes, 1/3 of the time they're going to have pre-diabetes, and then the rest are not. Okay, but you're going to screen them. All right. So with this condition, you're going to start off with like a reddish yellowish papule, okay, or nodule that's going to expand over time. And you're going to get a plaque, okay, that's going to have this kind of retained reddish brownish border. The center is going to become more atrophic and look a little bit more yellow. Now, because the skin becomes more atrophic in the center, it's going to be susceptible to injury, all right, and the formation of ulcers, okay? Okay, it's going to be most common on the shins. And in terms of your patient's symptoms, it's usually painless. Sometimes it can be a little pruritic. If there's an ulcer there, a secondary infection, that can be painful. All right. Treatment for this is going to be topical steroids under occlusion. You just have to be careful with that because of the side effect of atrophy. All right. So it's just something you have to keep in mind. You're going to want to tell your patients to certainly avoid trauma to the area. Another option would be ILK injections to the border of the lesion to kind of shut down the inflammatory reaction. Wound care, obviously, if there's an ulcer, sometimes you may have to, if the ulcer is not healing, excise out like the whole lesion and then skin graft. Okay. This is a pretty rare condition. I would tell you, I've only ever seen it one time. I had a patient who came in and they were being treated for years for stasis dermatitis. Okay, which I guess maybe, if you're looking at it, you might say there's hyperpigmentation there, maybe it's stasis derm, lower legs, he had comorbidities. But it has a very unique kind of appearance. So very long story short, I did the biopsy, it came back necrobiosis lipoitica, and then we got on the proper treatment. Okay, but just something you might maybe come across. I've only ever seen it once.